Alright, welcome back. In this video, we'll continue from where we stopped. We'll be talking about the proton pump inhibitors. Now, in the last video, I made you understand that these proton pump inhibitors, they are very important because they are the ones that inhibit the proton pump. Remember, the proton pump was at the center. So signals from the histamine, signals from gastrin, signals from M3 receptors, they are all converging at the proton pump. So if we can inhibit this proton pump, it will be very effective. That is why PPIs are one of the best drugs in management of peptic ulcer disease. They are widely used. They are widely used in clinical practice. Okay, so take note of them. So let's start. Proton pump inhibitors. Okay, proton pump inhibitors. So already I've told you guys the mechanism of action, but again, let's just repeat it. Let's repeat it. Imagine here is your stomach. Let me just put the diagram here. Imagine this is your stomach, then here is your small intestine. Then imagine on this side, here is a blood vessel that is passing through this place. So this thing I've drawn now is a blood vessel. So let me label this one as blood vessel. Blood vessel. Okay. Here is our parietal cells that are secreting the acid. Okay. Then here is the proton pump. 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 Are you getting it now? So if we take the proton pump inhibitors, drugs like omeprazole, they usually end with azole. Okay, although they're not the only drug that end with azole. Your fungi drugs, antifungal drugs, they also end with azole. Okay, but just take note that these proton pump inhibitors, they also end with what? With azole. So omeprazole, lansoprazole, and the rest of them. Okay, so when you take this drug, you already know that they will inhibit this proton pump. Okay, they irreversibly inhibit the pump. That is one thing I wanted to first take note of. They irreversibly inhibit the what? The pump. Irreversible inhibition. Now, let's take for example, somebody has taken this drug. This is the drug here now. Your first thought is that this drug will go directly and inhibit this pump here. That will be your first reasoning that, oh, the drug is going to go directly and inhibit this pump. But that's not how it works. These drugs are usually enteric coated. They're usually what? Enteric coated. Enteric coated because they are acid labile. They are destroyed by the acid in the stomach. Yes, they're going to reduce acid secretion, but if they get to the stomach the way they are, they will be destroyed by the what? By the stomach acid. That is why we usually coat them with an outer coating. Are you getting it now? So when you take this drug, they are coated, so they can't dissolve in this stomach. Rather, they will move down to the small intestine where they will what they will dissolve. So the drug has been dissolved now in this small intestine, where it will now be absorbed into the blood. Are you getting it now? It is now what? Absorbed into the blood. From here, it will pass through the basolateral part of the parietal cell and get activated inside the parietal cell by the acidic content of this parietal cell. It will get activated. Once it is activated, it will now inhibit this pump irreversibly. What am I trying to tell you? I'm trying to say that when you took the drug initially, the drug did not just come here and inhibit the pump. No, that's not how it works. The drug, first of all, will be absorbed into the blood. From there, it will first of all it was enteric coated. It then dissolved in the small intestine. It absorbed into the blood. From there, it gets into the parietal cell through the basolateral part of the cell, and then get activated in the cell by the acidic content of that parietal cell, and then inhibit the proton pump. How does it do that? Irreversibly. I'm stressing it now because later on when we talk about the H2 blockers, we get to realize that they are competitive inhibitors. They are not. They don't do this irreversible inhibition. These ones are what? Competitive. They can be, competitive inhibition, and they can be overcome when you give extra substrate. Are you getting it now? Okay. So, but this one, take note that they are what? Irreversibly inhibiting the proton pump. This is for their mechanism of action. The next thing we'll now talk about is their use. Where do we use them? Where do we use this proton pump inhibitor. So let's come to their use now. Let's talk about the uses of proton pump inhibitors. Okay, so on this side I will put the uses. Like I said at the beginning, they are widely used in clinical practice. They are very, very, very widely used in clinical practice, to the point that they are the drug of choice for peptic ulcer of any etiology. Any etiology, but there's a caveat to that, except stress-induced ulcers. They are the drug of choice for any etiology except what? Stress-induced ulcer. This does not mean that they cannot be used for stress-induced ulcer. They can also be used, but they are not the drug of choice for stress-induced ulcer. Later on, I'm going to tell you the drug of choice for stress-induced ulcer. But take note that PPIs are the drug of choice for peptic ulcer disease of any etiology except stress-induced ulcer. So the first use of PPI is they are the drug of choice for what? PUD of any etiology. Okay, the drug of choice for PUD of any what? Etiology. Also, they are the drug of choice for a condition that is called Zollinger-Ellison syndrome. Zollinger-Ellison what? Syndrome. They are the drug of choice for what? Zollinger-Ellison syndrome, which is a condition where there is excess gastrin production, which now leads to what? Excess acid secretion. So in Zollinger-Ellison syndrome, we have excess gastrin being produced. This gastrin then leads to stimulation of acid secretion, and from there the patient will come down with ulcer. You get, okay? Also, they are the drug of choice for gastroesophageal reflux disease, for GERD. Gastroesophageal reflux disease. Gastroesophageal reflux disease, that are the drug of choice for this condition. And also, apart from PPIs, prokinetic can also be used for GERD. Okay, but PPIs are the drug of choice for it. Okay, so take note of that. So you can see that they are widely used in clinical practice, like I've mentioned. So they're drug of choice for peptic ulcer of any etiology, the drug of choice for Zollinger-Ellison syndrome, the drug of choice for GERD. Okay, GERD. All right. So having seen this now, the next thing we'll now look at is we'll look at their pharmacokinetics now. Before we look at the pharmacokinetics, I want you to take note that PPIs, they can reduce acid secretion, both nocturnal acid secretion and functional acid secretion. They can reduce both nocturnal acid secretion and functional acid secretion, meaning that nocturnal acid secretion is the acid that is produced when the patient is asleep, when the patient is like not he has not eaten, or like on a normal day, for basal level as you are resting. That is called nocturnal acid secretion. Even at night, say when you are sleeping, it's constantly being produced. Okay, while functional acid secretion is produced when you eat. Anytime you eat, there will be acid secretion in the stomach. That one is called functional acid secretion. So PPIs can inhibit both nocturnal and functional acid secretion. Okay, is that clear? All right. So now let's come to their pharmacokinetics. I've already mentioned that they are given orally. So in terms of pharmacokinetics, they are given orally. Okay, they are drugs that are taken orally, and they are enteric coated drug. And these PPIs, you don't take them with food, rather you take them on an empty stomach. You take them on a what? On an empty stomach. Because why? They tends to food. If you take them with food, food decreases absorption, in the sense that it decreases, like it increases the gastric emptying time. It will take longer time before food will be passed out from the stomach compartment. Okay, so it decreases gastric emptying time. I know if food stay longer in the stomach, it is going to decrease absorption. You get, the time for absorption to take place will be decreased. It will it will take longer time for that thing to be absorbed. You are getting it now. So that is the effect of food in PPI. So you don't take PPIs with food. You take them on an empty stomach. And apart from that, PPIs are what we are drug that we call eat and run drug. Eat and run. They are called what? Eat and run. In the sense that this drug, they have a short half-life, but their effect in the body stays for long. They have a short half-life, but their effect in the body stays for what? For a long period of time. In the sense that, remember I said they irreversibly inhibit the proton pump. They irreversibly inhibit that proton pump. And by virtue of that, even if they are been excreted from the body, that they have been cleared from the body, the effect of that PPI still remains. So they hit the target and they run, in the sense that when they hit, they get excreted in a short term, but still yet their effect, that initial hit still remains. Okay, so they are hit and run drug because they irreversibly inhibit what? The pump. Are you getting it now? Okay, take note of that. They are hit and run drug. Now, example of PPIs include drugs like omeprazole. Omeprazole, this is a typical one. Okay, then we also have what we call lansoprazole. Lansoprazole. So lansoprazole is the most potent PPI. Lansoprazole is the what? Most potent what? PPI. We also have rabiprazole. Let me put this one here. Rabiprazole. So R for rapid. So rabiprazole is the fastest acting PPI. Is the what? Fastest acting PPI. We're still under the pharmacokinetics. Rabiprazole is the what? Fastest acting what? PPI available. Now we also have, there are some PPI that are given as IV. Remember we said these PPI are usually given as oral medication, but there are some that are given as IV. We have pantoprazole. Pantoprazole. Okay, pantoprazole is given as what? As an IV medication, IV PPI. Okay, so take note of that. Then I think these are the major ones. Rabiprazole, the fastest acting. Lansoprazole, the most potent, and omeprazole is just the typical one. Then PPIs, they also have a particular drug-drug interaction in their pharmacokinetic. You need to know this one, in the sense that they have the ability to inhibit a particular cytochrome enzyme that is called cytochrome 2C19. Okay, so imagine a patient now. Just imagine a patient that is on clopidogrel. Clopidogrel is a drug that has antiplatelet activity, so we give it for as prophylaxis for management of MI. Patients that are prone to having MI, we give them clopidogrel as prophylaxis. Okay, so now if you are managing such patients, let's say you have a patient on clopidogrel, so clopidogrel, okay, clopidogrel is a prodrug. It means that it needs to be activated to the active form of the drug in order for it to have an effect. So for clopidogrel to be activated, let me say this is the active form, it needs what? Cytochrome 2C19. Cytochrome what? 2C19. Now I just told you now that PPIs inhibit this enzyme. So imagine you still give this patient that you are giving for prophylaxis of what? Of MI. You are trying to manage the patient for any possible MI that is to come later on. That's why you are giving them clopidogrel. And now this patient also has ulcer, and you place this patient on omeprazole. So omeprazole tablets. Okay, this omeprazole, you know what it will do? It will inhibit 2C19. And if it inhibits 2C19, I believe you know what will happen. Clopidogrel will not be converted to the active form. And if clopidogrel is not converted to the active form, it will lead to therapeutic failure of clopidogrel. It means that the patient will likely have the MI in the long run. Okay, because omeprazole inhibits cytochrome 2C19. Okay, so take note of that. Omeprazole is there is majority of the PPIs, they have this cytochrome 2C19 inhibiting activity. The one with the least inhibition of that enzyme is pantoprazole. That is the one that is given IV. Okay, so take note of that. Omeprazole, desomeprazole, those ones, they all have that inhibition of cytochrome 2C19. Okay, so I believe we've talked about the pharmacokinetics, we've talked about the uses, we've talked about the mechanism of action. Now we'll talk about the side effects of patient taking PPI, and this is where we'll end PPI. So we're talking about the side effect. So what side effect do you think will come out from taking PPI? So side effect of PPI. What do you think are the side effects of taking PPI? I believe you are taking something. Imagine that there is no acid, like you decrease acid secretion. There are certain substances that depend on acid for their absorption. Are you getting it? There are certain substances that depend on acid for their absorption. For example, So the first side effect I'm giving you is decrease in absorption of one ion. No, ion requires acid in order for it to be absorbed. In order for it to change, I think for it to change to Fe2 plus. In order for it to be what? To be absorbed. Okay? It requires acid. Then imagine there's no acid. What will happen is that is going to lead to microcytic what? Anemia. So there will be what? Microcytic what? Anemia. Then again, B12 also require acid in order for it to be absorbed. That's why patients that have done that has atrophic gastritis, they can come down with B12 deficiency, in the sense that they will come down with megaloblastic anemia, or patient that has done gastric bypass surgery, in the sense that there's no more acid there, like they are not in contact with their stomach in a way. So they will also come down with B12 what? Deficiency. Okay, so take note of that. Meaning, as a side effect, there will be megaloblastic anemia on the long run, on a chronic what? Basis. Then also there will be calcium also depends on it. So the levels of calcium will also decrease. Okay, meaning there will be a tendency for brittle bone. Patient will likely have brittle bone, osteoporosis, all those kind of thing will come into play. Then lastly, magnesium level will also be low, because magnesium also depends on what? On acid to be absorbed. Okay, so taking note of that, the first side effect is decrease in absorption. Then the second side effect we want to talk about will be increase in certain infections. Remember that the acid acts as a protective barrier. It helps us to protect against certain infections. Okay, so infections like Clostridium difficile will increase. Okay, so taking note of that, infections like what? Clostridium difficile and other infections will increase. So there will be increased risk of what? Of infection. Third, the patient can also come down with dementia. Okay, patient can also come down with what? Dementia. But the two main side effect is the effect with that has to do with decrease in absorption, and the effect with increased risk of certain what? Infections. Okay, so that is for that. Then we'll now move now to, okay, I think we're done with the side effect now. We're done with the side effect. I believe here we'll end it here for proton pump inhibitors. Okay, see you in the next one. We're going to talk about inhibitors of H2 or H2 blockers. All right, thank you very much.